So good morning. My name is Ricardo Fontes. I'm a neurosurgeon at Rush University Medical Center, and it is a pleasure to be able to talk about the treatment of pyogenic spondylodiscitis for this new edition of humans. And as I say in the written version of this chapter, chances are that if you've come here for some guidance and some research, chances are that you're faced with a terrible case of a very sick patient. Some colleagues may be reluctant to intervene. Other colleagues may be pushing for diagnosis or source control or whatever it is. And so I hope you find some consolation in the fact that this pathology has spurred the development of many of the surgical techniques that we use today. And so many pioneers have been in the same situation as you have. And it presents a great opportunity for improvement of the surgery. And so without much further ado, this is the objectives of these presentations, basically to review the current guidelines for the diagnosis, treatment of bacteriodiscitis osteomyelitis. I hope I can convey a concise explanation about the rationale for surgery and discuss different treatment options as far as surgical intervention. So this is a pathology that's becoming more and more frequent. Right now, the incidence has been estimated in the literature as 2.4 cases per 100,000 people per year, but this is certainly much higher now. There are a number of reasons for this. Basically, more common situations where patients are able to get better medical care and otherwise very sick conditions such as end-stage renal disease. Patients are getting dialysis longer. Their complications of dialysis are being treated more aggressively. IV drug use on the rise in urban centers. Number of medical procedures are increasing as patients become older and more frail. The use of steroids. All of these are reasons behind which pyogenic spondylodiscitis has been increasing. The most common form of spread of infection to the spine is through hematogenous spread. So this is very important. Unlike other organs and systems which are exposed to the environment, like the lungs or the sinuses, the spine is a sterile place, and so the infection needs to reach the spine somehow. There's this much smaller fraction of cases which are due to contiguity, such as in pyelonephritis or esophageal perforation are the two most common cases, but by far and away, the most common presentation is due to bacteremia. The hallmark of pyogenic spondylodiscitis is its multi-compartmental nature, which helps us in the diagnosis, but also affects us in how we treat this. So it's not contained to the spine usually. It affects the cartilage of the disc, the adjacent end plates, the bone, the epidural space. Meningitis itself is rare, but epidural spread is common. And thus, besides, I really prefer this term pyogenic spondylodiscitis or vertebral, or basically describing the whole process as discitis osteomyelitis to reflect its multi-compartmental nature rather than just discitis. More common in the lumbar spine, followed by the thoracic and the cervical spine. This is one of the few situations in our specialty where we can benefit from the presence of clinical practice guidelines. And I highly recommend that every spine surgeon be familiar with the 2015 Infectious Disease Society of America clinical practice guidelines for the diagnosis and treatment of discitis in adults. This is already in its third edition. There are spine surgeons who participated in the confection of these guidelines, and unfortunately, many of the clinical specialists who deal with this problem are unfamiliar with it. And so it's important that we are able to base our treatment in the available evidence, because the quality of the data is actually relatively good. So diagnosis of this condition requires just basically one thing: a very good doctor. There has to be an elevated suspicion, a very low threshold to initiate investigation for this pathology. So the typical patient is the patient who presents with relatively acute neck or back or neck pain or dorsal pain and fever. This is one of those situations where those red flags of evaluation of a patient in the ER are present. So any situation where there is back pain and fever should trigger the investigation. Usually it starts with blood work. Inflammatory markers such as ESR, and especially CRP, the C-reactive protein, will be elevated. It has very high sensitivity. There are situations where that we need to rule out endocarditis as well. So sometimes these patients will be getting, in addition to the blood cultures, will be getting an echocardiogram to assess the valves. If there is evidence of bloodstream infection, even higher degree of suspicion. New neurological findings, and even those patients who are immunosuppressed in some way, patients who are IV drug users, type 2 diabetics, and stage renal, they all have to be investigated for discitis if they present with back pain. The imaging method of choice, far and away today, MRI with and without contrast. If that, all other imaging modalities are secondary to it, so nuclear medicine bone scan with technetium or gallium is now secondary, only to be done really in situations where MRI is not available. CT scan is more seen as either a screening tool, although it does not completely rule out the presence of discitis. Very early discitis may be negative on the CT. Or it's more common as a surgical planning tool. So I usually utilize the CT scan as a tool to be able to basically assess the amount of bone destruction to see if I need to do a reconstruction or if this patient is going to develop kyphosis. PET scan also can look for more remote sources. Blood cultures are always drawn in these cases. Always look for several different type of organisms. Again, the diagnosis of these atypical organisms can only be done if the clinician maintains a high degree of suspicion. And quantiferon gold assay is always useful to assess if the patient is at risk for mycobacterial discitis. This is what we typically see. This is a prototypical example of the of discitis osteomyelitis. So you can see a multi-compartmental infection involving the prevertebral space, involving the cartilage. You can see a large gap filled with fluid on T2 sagittal images, an epidural component causing stenosis, and very significant contrast enhancement. This can also have the presence of paravertebral abscesses, which is usually very suspicious of pyogenic infection. So psoas abscesses, thoracic prevertebral abscesses, those are very, very suspicious for discitis osteomyelitis. Here in the cervical spine, the same thing. So you can see the prevertebral phlegmon over here on the sagittal images. Extensive destruction, not only of the disc, but also the adjacent vertebral body, significant spinal cord compression by the phlegmon. In this case, there is meningitis, and you can see an intradural cyst over here caused by arachnoiditis. And then when this patient would try to sit up or bear weight, there would be kyphosis. The CT scan is sort of a surrogate to demonstrate the amount of kyphosis. The differentials include other forms of discitis, so spinal tuberculosis, fungal infection, especially immunocompromised, and brucellosis, especially in endemic areas. So Latin America and the Mediterranean are the most common ones. Here on this image, you have an example of mycobacterial discitis. So subacute discitis involving multiple contiguous levels, usually in the thoracic spine. Over time, this patient has been shown to have worsening and improving discitis at several different levels. So that's one of the hallmarks. Other differentials: amyloid spondyloarthropathy, a form of paraproteinemia from long-term renal insufficiency. It also is increasing those patients with kidney disease who are undergoing dialysis. More common in patients having actually peritoneal dialysis and some other forms of dialysis. So in the dialysis literature, you'll see there are different factors that will induce the development of this condition. Technical aspects of dialysis, the type of filter, but especially in these patients, always a differential to be kept in mind. This is a typical case over here. You can see that there's extensive bone destruction, but the adjacent, the paravertebral findings are not that pronounced. Charcot's joint or spinal neuroarthropathy used to be sort of a historical differential. I actually come across quite a bit of them. This is the example of a gentleman who was shot, had a T5 gunshot wound injury 40 years before in Vietnam, and who presented with this massive destruction and of distal to the level of the pathology. So these are patients who have some sort of denervation. The classic example is due to long evolution of type 2 diabetes with poor control, paraplegic patients. There's the disruption of the spine in multi-compartmental nature, virtually indistinguishable from the discitis, except that these patients will present with a low ESR and CRP. Also, tumors may present very much so like discitis osteomyelitis. This is an example where this patient had prevertebral involvement, had discal involvement. This is a case we reported, including was read as by the radiologist, suggestive of discitis at this level, had an epidural component in surgery, was found to have lymphoma. So very important to not only when performing biopsies, and not only send a material for cultures, but also for pathology as well. This is another example of a thoracic chordoma. The mobile spine, unusual location, where it was also initially read as discitis. So how to, proceeding to the diagnostic portion of the presentation, again, the most common form of spread is hematogenous, and so it's usually monomicrobial in nature. Diagnosis is made by demonstrating the causative agent, and by far and away the most common is Staph aureus. So according to the guidelines, demonstration of the pathogen in the disc material is not absolutely necessary. There are certain situations where this can be obviated. What the guidelines will state is that if there is history of recent infection by recent bacteremia by Staph aureus or Staph lugdunensis, or in less than 3 months, not simply at the moment of diagnosis, but recent, or if patient comes from an area of endemic brucellosis and has a strong serology response, and that can be looked up. It's basically a very acute serological response. Then biopsy is not really necessary. That can just be enough to treat the condition. You just assume it is discitis with imaging, and just proceed to go and treat the Staph aureus bacteremia, for example. There are some situations where there's some disagreement in the literature. So that is basically active bloodstream infection from other bacteria. So those situations where patients have discitis and have some other pathogen. So E. coli is relatively frequent, demonstrated in the bloodstream. There's some situations where there can be seen as there's some situation where you will find that that you will still have to go and do the biopsy, or other times if the patient is very frail, you just assume that's the one causative agent and you just go ahead and treat it. The guidelines are not very strong in that aspect. Eventually, most cases will need demonstration of the pathogen in the disc material, and so the most common form of initial biopsy is through a CT-guided biopsy these days. So percutaneous needle biopsy, you can, depending on who's performing the biopsy, there may be an attempt to get disc material. There's some literature saying that disc material and adjacent end plate can have a higher yield. The main thing is important for the proceduralist to send the material in saline and not formaldehyde when doing the biopsy. So you can still do PCR for mycobacterium to allow for quick diagnosis, and I have to wait 8 weeks for mycobacterial culture. You'll still send for mycobacterial culture. And then ideally, in the case of a non-diagnostic biopsy, that doesn't mean automatically surgery for diagnosis. There's some evidence that a second CT-guided biopsy may be useful prior to going ahead and doing the biopsy. So once the pathogen is identified or the condition is diagnosed, then treatment is really targeted antibiotic therapy. Empiric broad-spectrum antibiotic therapy is not really indicated except in the case of neurological compromise and sepsis. Another feature of antibiotic treatment is because of the poor vascularization of the disc is long-term. So long-term IV treatment for 6 to 12 weeks, depending on the patient's features. Follow-up is performed by serial ESR and CRP. So what we normally do is ESR and CRPs for the first couple weeks, every 3 days, to assess response, and realizing that it may not be completely linear, the response to antibiotic treatment in the first few days, but then gradually transition to every week or bi-weekly dosing of these inflammatory markers. MRI is not used to assess changes, to assess progress of treatment. This needs to be repeated over and over again. The MRI changes will progress up to a year after the initial portion of successful discitis treatment. So it's really only indicated repeat MRI in with new neurological symptoms or with failure as seen by rising SR and CRPs after 4 weeks of treatment. So this is a typical case, 63-year-old female with rheumatoid arthritis on steroids, so immunosuppressed, sick, septic arthritis with demonstrated Staph aureus, can't tolerate MRI, is the usual story. Can't lay flat, miserable, writhing in pain, multiple calls for neurosurgery when this case is demonstrated, concern for epidural abscess, but can't have MRI, so I don't know how you can demonstrate that. I'm sure you've been in this situation before, and there's also some degree of pseudo weakness. CT has been repeated, there's interval worsening, like I said, imaging worsening is the rule, not the exception during the initial treatment. Well, this lady had Staph aureus, was treated without a biopsy. This is how is the normal evolution of discitis, is eventually ankylosis. So once the disc is destroyed, there's cancellous bone, there's good fusion, there's this sort of tenet of neurosurgery that discitis cases fuse very well. Not so sure about that. I will show you some situations where that doesn't happen. But you know, if cancellous bones are exposed, if the patient can mount a response, this is the usual evolution of the case. The main thing as far as kyphosis, so there's always some degree of kyphosis because these patients will destroy the anterior column, is whether they can maintain alignment or relatively physiologic alignment. So in the thoracolumbar spine, normally if they can keep within 10 or 15 degrees of kyphosis, they will be able to maintain the cells. And so this lady never needed any sort of surgery, nor diagnostic, nor for treatment, nor for reconstruction. This is the typical history of discitis, really. As far as surgical indications then, what we're left with are the indications for diagnosis. So failure to secure diagnosis can result in request for an open biopsy. Neurological compromise, so decompression and treatment of the infection, especially the epidural component. Treatment failure requiring debridement, which is possible due to, again, the poor vascularization of the disc, instability and deformity. So for most of these indications, the preferred techniques are actually the MIS techniques. These are sick patients, infected fields, so they can benefit from less dead space, be it anterior, lateral, posterior for the technique. And at the same time, most patients will not have enough osseous restriction to justify instability infusion. So as you can see from this picture, this is the it's an MIS tubular approach to the posterior spine. This is usually what's necessary to perform an open. So this is a typical example, 83-year-old sick lady, back pain, elevated SR-CRP, negative CT-guided biopsy, has prevertebral phlegma, very suggestive exam, needed evacuation ×2 from my standpoint. The second evacuation, there was a little bit more aggressive debridement of the disc through the posterior approach. Did very well. So another example, 23-year-old with back pain, elevated SRM-CRP, IV drug user, has a discitis in the thoracolumbar transition, failed 2 times antibiotic courses. So he had an innovative pathogen, it was Staph aureus, but here the treatment was indicated, surgery was indicated for debridement and treatment of the infection. So it had a lateral approach with discectomy, placement of intervertebral spacer. We actually used a posterior interarticular spacer because we typically don't like to place plastic spacers in infected areas. This is data from the ortho literature. This has been done within the spine. It's just something I'm not very comfortable with. What we had was a T-lift spacer, so that's what was used, and unilateral fixation. As far as the need for large reconstructions, I mean, these are basically restricted to instability with deformity, which then is really a much bigger problem. I mean, because instability sets in very quickly, these patients don't have any ability to compensate for the instability, and so they become truly miserable. It's frequently the case that recurrent or sort of contained infection is still present, but this is derived from the fact that the anterior column is preferentially destroyed, and as such, these patients develop kyphosis very quickly. Once this sets in, though, it leads to a very unfortunate situation there that with non-operative treatment, bracing, etc., they don't really do very well. So these patients sometimes will linger for years and years until somebody actually decides to go in and reconstruct it, with a caveat that these are very sick patients. So again, the treatment is really based on anterior column reconstruction, whatever way you do it. The MIS, lateral anterior is the classic way because of the development of new deformity techniques. We've been doing these complete posterior now. So this is the classic example of post-infectious instability. So 56-year-old, Staph aureus, 3 years of so-called treated discitis with this massive deformity and thoracolumbar kyphosis. These people are absolutely miserable from this deformity. So it was all reconstructed from a posterior approach using deformity techniques. It is by all means a very morbid procedure, but patients do well, and surgeons attempting these reconstructions are highly encouraged to have a very well-defined protocol to get these sick patients through basically what it is, a deformity. This is another example, 68-year-old with a remote placement for spinal cord stimulator for low back pain, had an L4-5 spondylodiscitis. Basically 3 years after so-called treated urosepsis. Vertebral column reconstruction, as you can see, very, very effective, complete resolution of pain. So just to wrap up this presentation, a challenging pathology by all means, and very challenging patients. You will be working closely with a lot of colleagues, not simply internal medicine, anesthesia, but also infectious diseases, interventional radiology, and communication is really key to establish expectations and to establish a joint treatment plan. And also make it evident to our colleagues that surgery is really necessary in a minority of cases. So, and when surgical indications are really appropriate, these are typically done in MIS fashion and just restricted diagnostic and debridement. Should deformity and instability become established, though, then really you have to address it very proactively. And the mainstay of treatment is really long-term narrow spectrum antibiotic therapy with follow-up with routine ESR and CRPs. And again, never enough to repeat, routine MRI is not indicated for assessment of treatment response to discitis osteomyelitis. So thank you for the attention, and I hope this was useful. Good luck in your next discitis case.